Welcome, everyone. I'm Morgan Roberts, the CEO of GACD. It's great that you've taken time out of your busy day to join us here on World Diabetes Day 2024. And to mark this day, GACD are really excited to be launching a new report which captures a large body of work undertaken by those projects supported through our Diabetes Research Programme. I'll just put up the next slide and to give a quick look at what you can expect from this launch event. So, as I said, I will provide a very quick overview of GACD to set a bit of background and scene. I'll then invite our lead author, Maisha Syed, to introduce the report. And we will hear from some of the project teams spotlighted in the report itself, before moving into a panel discussion with audience participation and then moving to a closeout. It's really great that we've got project team members, we've got funding agency representatives, and we've got the greater public watching our event launch today. Great. So let me start with a quick introduction to GACD, because not all of you may know what is the Global Alliance for Chronic Diseases. Well, we are what it sounds like. We are an alliance, and we were the first, and we actually remain the only, as far as I'm aware, collaboration of major international research funding agencies who have come together to address chronic non-communicable diseases. The next slide shows the flags where the funders who are in the alliance are currently based. But you should note that we actually support research in over 80 countries worldwide. Next slide, please. A key aim for GACD is through our research to provide evidence that will help to inform policymaking on the prevention or control of chronic NCDs and to thereby reduce inequities in health, particularly in resource-constrained countries or amongst marginalised populations. A central focus of GACD has become implementation research, and to date, we have jointly held 8 research calls and supported a total of more than 185 projects at a total investment of over $375 million US. Next slide, please. The funded projects from each call come together collectively as a research programme. One of these research programmes, of course, being the Diabetes Research Programme. And within the network, we foster knowledge exchange, collaboration, and networking by bringing all members of project teams together as our research network. Next slide, please. I noted that for GACD, a central focus was implementation research, and I thought it worthwhile to just take a moment to very, in simple terms, explain this field of research. For several NCDs, including diabetes, we already know that there are a number of interventions, or let's say things, that we can do to prevent or control disease. In type 2 diabetes, for example, it's been shown that improved diet or increased exercise are things that can work to reduce the risk and to prevent diabetes. Implementation research looks at how best we can help people or places do that thing. And researchers explore different strategies that may help do that thing, given the specifics of the system and setting they're located in. I think it's really important to understand that nations need context-specific global research to inform their own practice and policy. And this is what GACD research projects around the world aim to provide. So I hope with that very brief introduction, I've set the scene, and we're going to turn our minds very much back to diabetes.
I'm really delighted to pass the mic over to Maisha Syed, who was our lead report author, who's going to take us through the report that she compiled and wrote and was contributed by all of our wonderful researchers. Maisha, over to you.
Thanks, Izzy. Hi, everyone. I'm Maisha Syed, and as Izzy and Morven have said, I am the lead author on the diabetes report from the GACD. So I'm going to be giving you an overview today of the report, and with the help of my colleagues Carolyn and Margaret. Next, thank you. So when developing this report, we had 4 main aims. Firstly, we wanted to descriptively summarize all the implementation research projects that were funded under the GACD Diabetes Programme. And this consisted of 14 projects across 19 different countries. The second aim was to provide an initial synthesis of the trends that we found across all of those projects. So any similarities, differences, and the stories that came out at a project level. But we did realize that this was a bit of an ambitious aim to have, especially alongside the challenges that exist within the implementation science field. So a whole meta-analysis style approach would not have been possible. And with that in mind, we purposely aim to develop a report that can act as a starting point and serve as a springboard for researchers to continue the work and consider future research in the implementation and diabetes community. And that leads nicely onto our fourth aim, which was then to prompt our readers to build on the interpretations that we've presented in this report and apply their own expertise, perspectives to this initiative, or indeed take inspiration for their own work. When preparing the report, this took place over broadly 3 stages: data collection, analysis, and interpretation. To collate the data initially, we created a 27-question pro forma, and this was developed in collaboration with the primary review group. The form contained in-depth questions across various themes ranging from study design to key findings, giving structure whilst also allowing space for projects and research teams to provide more reflections using open-ended questions about things such as perceived or achieved impact. These proformas were sent out to each of the project teams to complete, pre-filled with any information that was already contained within the GACD database. And once these were completed and returned, the analysis stage began. The data from these proformas were extracted into a database with fields that corresponded to the questions in the form. And by using a narrative synthesis approach, we tabulated and grouped the data by different parameters, such as implementation strategies used or barriers faced and things of the sort. These findings were then finally interpreted initially and then presented for review and iteration by the report contributors.
So, the Diabetes Research Programme was launched in 2013 with the aim of funding implementation research projects focused on preventing and/or managing type 2 diabetes in low and middle income countries and in underserved populations in high income countries, including some indigenous communities. 10 agencies offered funding through this call, and 17 projects were then awarded. 2 of those were subsequently not funded, and a total of 14 took part in the development of the report. The funders together invested over $21 million into this programme.
Thanks, Carolyn. So as mentioned, there were 14 projects in total included in the diabetes report. And as you can see on the slide, each project has been given a shorthand code, which we use to refer to them with ease. Of these projects, 3 of the projects focused on gestational diabetes or diabetes in pregnancy, and those were DM1, 3, and 16. The rest of the projects focus solely on type 2 diabetes. These 14 different projects spanned 19 countries and 5 different WHO regions. Some of these countries hosted more than one project, with Mexico and South Africa each hosting 3 projects and Bangladesh hosting 2. Each project also aimed to address specific implementation gaps with their research. And after analysis, it was found that the majority of the projects aimed to improve health promotion. As you can see from the figure, 7 of the projects had this goal. Cost-effective health screening, prevention and/or control programs, and improved quality of care and/or access were also common goals used by 6 and 5 projects, respectively. Each team was also asked to provide information on different stakeholder groups engaged with during the project. And after service users and healthcare professionals, which were groups that were engaged in all projects, the most commonly engaged stakeholder group was local policymakers. It's worth noting here the importance of stakeholder engagement for impact, which we will cover shortly. And sorry, can we just go back for 1 second? Thank you. One of the projects that had quite a lot of stakeholder engagement that was quite interesting was Project DM01, the Diabetes in Pregnancy project in remote Australia. We had a talk from Renee about this in the morning session, and if people would like to catch up, they are welcome to tune in to the recording. But there are a variety of project spotlights throughout the report, focusing on different key aspects like stakeholder engagement or context. And stay tuned later today for some more presentations on a couple more project spotlights. Now, moving on to study designs and methods. Across all of the 14 projects, 6 different study designs were used, and that reflects the inherent diversity of methodologies and the meeting of many disciplines in implementation research. Project teams reflected on their methods and approaches as part of the pro forma that they completed initially, and it was found that mixed methods were the most favored approach. Similarly, a range of theories, models, and frameworks, TMFs for short, were used, 17 in total, in fact, with the most common being COM-B, RE-AIM, and the MRC framework. TMFs were also used for a variety of applications throughout all the projects, namely refining formative work and in designing and preparing the project, or refining the implementation strategies used, and for evaluation. Importantly, it was found that TMFs were multi-purpose, with 11 of the TMFs used across the 17 in total being used for more than one purpose across all projects. One of the most interesting findings from the report was about context-specific barriers and enablers faced by each project. Collating this information is important for indicating common obstacles and allowing space for preparation before a project even starts. Most factors were consistently barriers, such as data collection, recording, and referrals, or consistently enablers, such as stakeholder support across all of the projects as a whole. However, some factors differed depending on the setting. For example, some community behaviors like efficacy of stress management or perceptions about livelihood of living with disease, and dietary and exercise habits. In some settings and population groups, these projects found debilitating stress management practices such as increased drinking or smoking, whereas others found beneficial practices like meditation or exercise. Similarly, for perceptions of livelihood with disease, in some contexts, fear was found to put service users off engaging with healthcare professionals or taking medication as they were advised to. But in other contexts, fear had the opposite effect and actually motivated the service users to stick to their medication protocols. A major part of the report tried to categorize the implementation strategies used across all the projects. At this point, it's really important to highlight some challenges that were faced. As implementation science is a field that continues to evolve, there is still a lot of room for standardization in terminology and frameworks. The first GACD diabetes projects began in 2014, and over the last decade, much of the language has changed. So there still remains this gray area with terms such as intervention, implementation strategies, or activities used. As a result of this descriptive and linguistic diversity, it was difficult to unify the data using a contemporary framework, such as the one that was proposed by the ERIC project. However, for the purposes of this report, we established a consensus in our categorization of implementation strategies, while remaining clear that it may be possible and equally valid to examine these groupings in other ways. Again, this reiterates our point of our fourth aim, or our third aim even, of being a springboard for future implementation science research and further reflection about the field moving forward. We ended up using the PEDALS framework to guide our categorization, which made the most recent and coherent attempt at standardization. Subsequently, we came up with these 9 implementation strategy themes that you can see on the screen now. Of these themes, the most commonly used amongst all projects were knowledge building for service users and mHealth. mHealth contains telephone calls, text messages, voice messages, and mobile applications and/or software. Analysis of how implementation strategies interacted with each other provided insights into trends across commonly grouped themes. This creates scope for future tailored research in these areas. One example of this is within the mHealth category, where telephone calls and voice messages were always accompanied by facilitator-led group sessions, but not vice versa. Another example was that health promotion materials were always accompanied by knowledge building for service users, as were community health programs and community mobilization. At this point, it's also important to highlight efficacy amongst these implementation strategy themes. Although it was found that mHealth alone wasn't effective, combining it with strategies, however, especially with strategies like knowledge building and community mobilization, significantly boosted success rates, with over 80% of projects reporting positive outcomes. So this may suggest that a holistic approach to digital health interventions may be the key to success.
So as we heard earlier, a key aim of implementation research is to generate findings that influence policy and practice. We asked these diabetes projects to report on their impact to date, and 12 out of the 14 projects reported an impact. These impacts are described further in the report, but can be summarised into 3 main themes, as shown on the slide. Several projects reported that they strengthen national health systems to respond to the burden of diabetes. This included building the capacity of the health workforce, strengthening health systems to support the delivery of effective interventions, and strengthening referral systems. A number of projects reported an influence on national health programmes, strategies, or guidelines. These projects reported that integrating interventions within existing national health systems
as well as close engagement with local and national policymakers, were critical in contributing to these impacts and also increasing the likelihood of sustainability. Two of the diabetes projects received further funding from the GACD to be scaled up. We're going to hear one of those in our project spotlights later. Some other projects have received funding from elsewhere, including government funding and other sources, or endorsement from the government to scale up their projects, whereas others have informed further research. It's widely acknowledged that creating impact takes time, and many of the diabetes projects has only actually been completed quite recently. So we do anticipate that we will see further impacts from these projects over time. And Maisha's already mentioned the project spotlights that are throughout the report. Some of those describe some of the impacts in more detail, and we also have a series of case studies on our website, and I'll share the link in the chat if you're interested in looking at those case studies. Thank you.
Thanks, Margaret. So in conclusion, after analysing these projects, we found overall 6 core lessons were learned. Firstly, collaboration for success. As mentioned a couple of times, the engagement with different stakeholders was greatly important. Tailoring to context, such as understanding the barriers or enablers behind a given setting. Seeing that technology is a tool and not a silver bullet, as mentioned with the efficacy of mHealth in a more holistic approach. Addressing health inequities, because inequitable access to healthcare will inevitably have knock-on effects. Considering sustainability from the start, so having more rigorous pilot programs or formative work. And finally, expecting the unexpected. One of the biggest things that affected the projects in this timeline was the COVID-19 pandemic. Of course, nobody could have expected that to happen, but the lesson to take away from this is to expect to take detours despite having rigorous planning. So that brings me to the end, and I'd like to thank each project research group for their contribution and collaboration on this report. Without that, it really would not have been possible. I'd also like to thank our reviewers whose input and feedback helped create iterations from draft 0 to the final product. Thank you very much.
And of course, Maisha, thanks to you. And thanks for that really comprehensive summary of the report. It is a really impressive body of work, and you worked very hard to tease out the trends and commonalities across a diverse programme of activity and projects worldwide. You're really to be congratulated on what you've managed to achieve. And thanks for coming along today to present the report. Thanks, Maisha.
Thank you.
I think we'll do that virtual round of applause as one thing. Okay, so I'd like to move on now at this point to actually some of the project teams who are here today, and their projects were included as project spotlights within the report itself. To introduce the project team, we have representatives from our funding agencies, which is great too. So Amanda, I'm going to start off with you.
Wonderful. Thank you so much. And thanks for the overview of the report. That was fantastic. Hi, everyone. My name is Amanda Nguyen. I'm a program officer at the NIH Fogarty International Center. It is my honor and pleasure to introduce our speaker today, Dr. Rajesh Vedanthan. Dr. Vedanthan is an associate professor in population health at the New York University Grossman School of Medicine and a true leader in promoting global health equity. A cardiologist and epidemiologist by training, but an implementation scientist at heart, while also pulling in economics, data science, and frankly, so many more fields of scholarship than I was given time to go into, has been working to address gaps in delivering evidence-based care around the world through innovations in health workforce strategies, health information technology, and directly addressing social determinants of health. If that isn't impressive enough, Dr. Vedanthan has been honored not only for excellence in scholarship, but also for an incredible commitment to mentorship, teaching and service to the field and to underserved communities, and has been an active member of the GACD network for many years, much longer than myself, in fact, which is why it is truly my great honor to be a part of this event and to introduce and turn the floor over to you, Rajesh.
Great, thank you so much. Thank you, Amanda, for that very generous introduction. And thank you to Morvin and the rest of the GACD leadership team for inviting me to present today. Thank you so much. Happy and honored to be able to share the work of our team. So I'm just one representative of multiple folks working on this project. Really to provide a sense of the context within which our trial, the Big Pic trial, took place. And so I've titled the presentation, Social Determinants of Health Context for the Big Pic trial. Next slide, please. No corporate disclosures. These are some of the federal and foundation grants that I might refer to during my presentation today. Next slide, please. Just before we move on to the content of my presentation, we're all involved in global health. The reality is that the current practice of global health did arise from the sort of experience of colonialism. Many of the vestiges of that history still remain with us today in the forms of, economic extraction, disparities, inequalities, even forced displacement of populations, et cetera. So I just wanted to share a few words, cautionary words, before I move on to the content of my presentation. A friend and colleague of mine, Madhukar Pai at McGill, has written extensively about this topic, and I just wanted to share a few words from a blog he wrote a few years ago. Next slide, please. Imagine this scenario. A couple of newly minted Master of Public Health graduates from an African university, say in Rwanda, land in Washington, D.C. for a 2-week visit. They visit a few hospitals, speak to a few healthcare workers and policymakers, read a few reports, and write up a nice assessment of the US health system with several recommendations on how to fix the issues they saw. They submit their manuscript to the American Journal of Public Health. Next. Can you imagine the journal even sending it out for review? Even if the paper got published somewhere, would US health researchers take it seriously? And then he puts in parentheses, they should, I suppose. After all, the broken US healthcare system needs all the help it can get. Next, please. Clearly, it's an impossible scenario, yet American graduates land in low-income countries to advise them on global health issues all the time. I met an African expert recently, and she expressed her frustration about how American kids with little or no experience come all the time to advise her government on what to do about health. So with just those few cautionary words, I wanted to now continue with the rest of my presentation. But just to keep in mind that we should be as respectful and responsible in our global health practice as possible. Part of the context that has already been presented, obviously, and I apologize, my camera is acting up on me today, is that there's an incredible burden of diabetes and other non-communicable diseases around the world. So I won't go into that background information here. But one of the problems with respect to management of diabetes and other non-communicable diseases is poor availability of medications. And this was a figure put together by colleagues of mine a few years ago, basically showing that in some low-income countries in rural areas, as you can see here, less than 5% of individuals actually, 5% of pharmacies even stock medications for cardiovascular disease and other non-communicable diseases. Next slide, please. Even when they are available, they're not affordable. And here are shown 4 cardiovascular medicines, many of which are actually used in the sort of auxiliary management of diabetes. Again, demonstrating that in some rural areas of low-income countries, nearly 50% of a household's capacity to pay, essentially 50% of a household's monthly income, going towards these 4 very basic medications. Next slide, please. And studies from around the world have shown that the household level cost of non-communicable diseases is quite substantial. Nearly 30 to 40% of households around the world experiencing catastrophic health expenditures. And it's really an unsustainable economic situation that many patients and their families face. Next slide, please. In our study in Kenya, we saw that nearly 70% of our population was either unemployed or earning less than $50 per month, so less than $1, $1.50 per day. So that very severe level of poverty or unemployment is an economic reality and context that we have to deal with in the context of our work. And I think it's actually similar to many places around the world. Next slide, please. We also were able to show that food insecurity as a marker of economic vulnerability was associated with difficulty accessing care, that the more food insecure people were, reflecting more economic vulnerability, they had more difficulty accessing care. Next slide, please. And so this really brings me to this conceptual figure of really thinking carefully about the social and structural determinants of health, the conditions in which we live, in which we work, and in which we play that actually have a major impact on our health. Next slide, please. In our case, we were really focused on the socioeconomic issues related to poverty and economic opportunity, but many other social and structural determinants of health, air pollution, environment, social networks, racial discrimination, etc., are all very important social and structural determinants of health and contexts that need to be taken into account in terms of the management and prevention of diabetes and other non-communicable diseases. Next slide, please. So my work is in Kenya that I'm going to be reporting today, working with the AMPATH group in Western Kenya. Next slide, please. AMPATH is an acronym standing for Academic Model Providing Access to Healthcare. Next slide, please. It's fundamentally an academic global health partnership that started with Indiana University, partnering with Moi University, Moi Teaching and Referral Hospital in Western Kenya, but has expanded to a consortium of over 15 different institutions, some of which are represented here. Next slide, please. And the idea is to advance the tripartite mission of academic care, academic medicine, leading with care, strengthening care delivery, strengthening health systems, and then leveraging that foundation for meaningful capacity building and research. In addition to our non-communicable disease work, we actually established a comprehensive HIV care program in the early 2000s to address both clinical care for HIV as well as social determinants of health. We've treated over 200,000 individuals living with HIV. We're amongst the first groups to really convert HIV from a death sentence to a livable chronic disease on the continent of Africa. And we've since leveraged that HIV infrastructure for chronic disease care and implementation research, all the while incorporating social determinants of health into our work. Next slide, please. Just here, wish to give a shout out to my primary colleague and collaborator, Jemima Kamano, pictured here on the left, and her nurse manager, Deborah Tulienge, on the right. Really, without their leadership and literally blood, sweat, and tears, I wouldn't be here today. So I just wish to thank them. Next slide, please. And so the question we asked ourselves in the context of the Big PIC trial is how do we now incorporate these social determinants of health into NCD care for diabetes and individuals with at risk for diabetes? Next slide, please. And again, just to sort of remind you that our focus was on the sort of poverty and economic opportunity aspect of social determinants of health. Next slide, please. We borrowed from the tradition of and practice of many of our HIV colleagues, where they had also addressed some of these same economic issues, trying to improve gainful employment opportunities for individuals living with HIV, pictured here in textiles. Next slide, please. Agriculture. Next slide, please. And those evolved over time to these self-sustaining microfinance groups where individuals with a common condition, chronic condition, would come together in groups, loan each other money so that they could then pay off either commitment accounts such as health fees or school fees, or invest in their own small businesses, farming, poultry, etc. Next slide, please. And so our trial, Bridging Income Generation with Group Integrated Care, which was our GACD and NIH-funded project, next slide, please, was really to try and tackle that economic issue and that social determinant of health head on. We brought together patients living with diabetes or at risk for diabetes, living with hypertension, into these groups where they could address their economic issues while at the same time being able to provide them care in these group medical visits, ultimately hoping to reduce cardiovascular risk. Next slide, please. And what we were able to demonstrate is that the combined group medical visit microfinance arm on the far right hand of this bar graph did lead to superior blood pressure reduction relative to usual care. Next slide, please. And that if you look at the subgroup analyses, there were certain subgroups. Women in particular tended to have better outcomes. Individuals with no job or lower wealth indices also tended to, in general, to have better outcomes. It's a fairly loud graph here, subgroup analysis, but basically showing that certain subgroups, again, thinking about context, thinking about social determinants of health, thinking about gender power dynamics, thinking about economic opportunities, really did have an impact in terms of the effectiveness of our intervention. Next slide, please. One of the other things that we showed was that social networks did also strengthen over time, that sense of cohesion or trust or connectedness did actually strengthen, if pictured from the left, where that was at baseline, to the right, where we had much stronger social networks, which we are now analyzing and showing that those did contribute to some of the blood pressure changes we saw. Next slide, please. And finally, that we've actually done a cost effectiveness analysis, demonstrating that actually the cost effectiveness question is actually more complex than just yes or no. It's really about willingness to pay. And that sort of x-axis on the right basically shows that depending on your willingness to pay, different interventions may actually be more cost effective than the other. And I'm happy to go into details in the Q&A. I don't want to take up more time here. Next slide, please. So just in conclusion, NCDs and risk factors are a global problem. Social determinants of health are a dominant factor. We can translate many of those challenges into opportunities and incorporate social determinants of health into care delivery, really emphasizing the importance of rigorous implementation research. Thank you so much.
Thank you, Rajesh. That was a very speedy tour through your project. Really interesting synopsis there. We're going to move swiftly to our next project spotlight. And I think, Kate, we're going to invite you to do the introductions here. Thank you.
Thanks so much, Morven. A pleasure to be here. My name is Kate Fröhlich. I'm the Scientific Director of the Institute of Population and Public Health at CIHR, which is Canada's Federal Health Research Funding Agency, or the NIH of the North. Since our earliest days, CIHR has always supported global health and has taken on an important leadership role in supporting and funding global health research in Canada and abroad. And indeed, one of CIHR's most impactful partnerships is with the Global Alliance for Chronic Diseases. Since 2011, CIHR has invested over $30 million to support GACD research grants, and we're so pleased to have been able to co-fund the Community Health Assessment Program in the Philippines as part of the 5th GACD call in collaboration with our partner, the International Development Research Center. So it is my great pleasure to introduce principal investigators, Drs. Gina Agarwal, professor in the Faculty of Medicine at McMaster University, and her colleague, Dr. Ricardo Angeles, assistant professor from the same institution, who also works at the Ateneo de Zamboanga University in the Philippines. Today, they'll share their findings and the impact of their project CHAP-P. On behalf of CIHR, congratulations to you both on your remarkable achievements. Over to you.
So thank you very much for that introduction, Kate. It's very nice to be here. I'm very privileged and excited to present the study and some of the results of the project that we conducted in the Philippines, along with the leadership of our Filipino colleagues, of course. And I also want to mention especially our colleague, Dr. Fortunato Cristobal, who is the Dean of the School of Medicine at Ateneo de Zamboanga University in Zamboanga province in the Philippines, without whose leadership this project could not have taken place. So I'm going to be presenting with Rick here a few slides to take you through the project. Next slide, please. So the CHAP program, or this program, was started as the CHAP program, which stands for the Cardiovascular Health Awareness Program. And this was developed in Canada and originally was focused on hypertension and cardiovascular risk. However, this was extended to other implementations of the program in Canada to include a diabetes focus as well. So mainly diabetes screening and risk assessment. And the CHAP program was proved to be very effective because a large community cluster randomized controlled trial in Canada demonstrated that there was a statistically significant 9% reduction in stroke, heart failure, and heart attacks. And therefore, we felt that this program would be suited to low-resourced communities because it was a low-cost program, it was very highly implementable, and its strategy was very population-based, targeted towards health promotion and disease prevention. Next slide, please.
So we decided to conduct a multi-phase research project, and which we conducted between 2014 and 2019 in select communities in the Zamboanga Peninsula of the Philippines. And there were 4 distinct phases. So the first phase was a qualitative phase where we worked with stakeholders and we wanted to understand what the context was for any adaptations that needed to happen. The second phase was a pilot phase where we tested specific elements of the program, like, for example, were the blood pressure cuffs appropriate and the machines available, that kind of thing, could they be used? The third element was the randomized controlled trial, which is what we're really going to focus on presenting today. And that was to evaluate the effectiveness of the CHAPP program. And then the last phase was a knowledge translation and data analysis phase. And that's kind of ongoing now as we are scaling up and out in the Philippines. So we're really going to focus today on phase 3, which was our cluster randomized controlled trial, which was a 6-month, 26 community parallel cluster RCT that took place in 2018 and 2019 in 5 municipalities. So I think we're going to go to the next slide now.
So our program of research is the Community Health Assessment Program in the Philippines, which, next slide, please. It was born out of a long-standing partnership between McMaster University in Canada and also the Ateneo de Zamboanga University in the Philippines, in southern Philippines. I used to work in the Ateneo de Zamboanga University, and prior to this current project, we had other smaller projects which started since 2003. So it's a very long-standing partnership. CHAPP was the first full adaptation of the Canadian program to a low and middle income country, and we're planning to implement it to other settings in other LMICs. Next slide, please. So as to the methods, Jean already mentioned that, presented earlier, that it's a multi-phase trial starting with the adaptation of the intervention, a pilot study followed by a cluster randomized controlled trial. Next slide. The main element of the intervention is the CHAPP sessions, which were bi-monthly walk-in sessions in rotating villages, or in the Philippines, what we call as barangays. The CHAPP sessions are led by volunteer health workers or barangay health workers. The sessions are free of charge. They're aimed at community residents 40 years and older. And during the CHAPP sessions, it included risk assessments, specifically diabetes risk assessment using the FinRisk tool. We had blood pressure testing, BMI, waist circumference measurements. Also, it included education regarding the risk factors on how to decrease, or education regarding their risk factors and how to decrease these risk factors. And depending on the risk assessment of the participant, there was referral to the municipal health office or other health services available in the community when needed. So the diagram in this slide shows a sample of an algorithm in our electronic database behind the referral process if CHAPP participants are at risk of developing diabetes or if they have elevated blood pressure. Next slide.
So since the trial was primarily about type 2 diabetes, it was really important for us to have a population level diabetes outcome as the main outcome. And we decided that the primary outcome of the RCT would actually be the mean difference in HbA1c in the community dwelling individuals at 6 months compared to individuals in the intervention communities versus control. And this would be whether they had actually attended the CHAPP intervention or not, because we wanted an overall community level outcome. And we actually thought that some of the effects of our intervention would potentially be able to affect all individuals in the community, whether they had attended the program or not. And it was, quite an ambitious notion, but let's see what happened. Next slide, please. I just want to present also some of the secondary outcomes as well.
Of course, we had a number of them, but the ones that we're going to talk about a bit today will be blood pressure, both systolic and diastolic, quality adjusted life years using the EQ5D, which is a widely used quality of life tool, risk factors for diabetes, which are part of the FINDRISC diabetes risk assessment tool, and knowledge of both diabetes and hypertension as chronic conditions, and perceived concern and understanding of risk for both diabetes and hypertension. Next slide, please. So in the next few slides, we are going to outline the main results findings from the CHAP-P trial. Next slide.
So this slide shows the implementation of the community intervention and participation of residents in the program. Overall, there was an estimated about 32,000 residents who were eligible to attend the CHAP-P session. So these were residents over 40 years old. Out of these 32,000 residents, 3,000 actually attended the CHAP-P session, so about 10% of the eligible population attended it, and 1,500 attended 2 or more sessions. We emphasize that they should attend 2 or more sessions because it's important to follow up regarding their risk factors and also how they're doing. And there was a significantly higher participation rate in rural communities, about 28%, compared to only 7% in urban communities. Next slide, please. And participants in the evaluation process, actually, there was a lot of group of participants who took part in the evaluation of the program. 3,000 of them, as I already mentioned, attended the CHAP-P sessions, the intervention itself. About 5,200 were interviewed for the outcomes before and after the study, 2,600 at baseline, 2,600 6 months later. And then 68 implementers participated in some qualitative evaluation, either by focus groups or some of them through key informant interviews. Next slide.
So this slide is important because it actually depicts information about who were the people that attended the program and what their characteristics were. And we can see that we have a variety of age groups of participants, well distributed across most of the adult age groups. They're mostly female attendees, nearly half were obese, and we can also see the high prevalence of risk factors. So 2/3 with a higher waist circumference, as well as 1/3 with an elevated diabetes risk score, and 40% with elevated blood pressure. And when we look at the outcomes of the attendees over time, not surprisingly, we can see that the systolic blood pressure significantly decreased over several visits. And therefore, attending multiple CHAP-P sessions was very beneficial to participants. Not only did the systolic and diastolic blood pressure decrease, but also their weight went down, as you can see. And the drop in systolic blood pressure and the drop in weight was significant over time. Next slide, please. So we had also conducted a community survey from which we were going to extract our community level results, which, if you remember, our primary outcome was from the community. So the survey had been completed at 6 months after the beginning of the trial, after the intervention had run, and we had used a systematic random sampling method that had been used at the household level. Now, when we look at characteristics of individuals in the survey, we can see that the demographics are similar between the intervention and control groups. We have a good range of ages, fairly similar as well. We have more women because probably they were at home and men were out working. We can also see that the risk factors are similar to each other, 30% overweight, 11% obese, around 30% with an elevated waist circumference. Next slide, please. When we look at the risk factors in both the control and intervention groups, they're also fairly balanced, except for maybe a few variables. I think physical activity was slightly higher in the intervention group. But you can also see just how many people we sampled as well. You know, I want to point out that we had more than 1,000 individuals in each of the control and the intervention groups in the communities. And you can imagine what a vast undertaking that was for us. Next slide, please. So when we specifically look at the primary and secondary outcomes in the trial, we can see that most results were in fact in favor of the intervention group. So importantly, although the primary outcome, which is the A1C, was not statistically significant, the intervention mean A1C was lower by about 0.14, which would be, you know, clinically relevant. I would argue. Unfortunately, it wasn't statistically significant. However, we did have significant results in that the blood pressure was lower, diastolic blood pressure was lower in our intervention group. And next slide, please. And let's just look at some of the secondary findings. Again, when we look at the secondary findings, all of them were actually significant in favor of the intervention group when it came to individuals' understanding of blood pressure and diabetes. And remember, these were not people who had necessarily attended the program. This was just people in the community. So the intervention had definitely been an educational one. And so we had kind of expected this, but these were very good results for us. Next slide, please.
So at the beginning of the research, we had an a priori hypothesis that CHAPI might have different effectiveness in rural versus urban communities in the Philippines, knowing that residents in rural communities tended to have better health-seeking behavior and attended health programs more. So we conducted a sensitivity analysis comparing the outcomes of rural versus urban communities. And just as a reminder, about 27.7% of eligible population in rural communities attended the program compared to only 7% in urban communities. Next slide, please. So of these outcomes, you can see that the rural communities in CHAPI had significantly better HbA1c and knowledge of diabetes compared to control communities. That's in the rural areas. Urban communities had significant improvement in both systolic and diastolic blood pressure, but the HbA1c was in the negative direction. Next slide. For the secondary outcomes, rural communities had significant positive results across all the understanding, concern for the chronic diseases, perceived behaviors, confidence in improving their behaviors for both diabetes and hypertension. While urban communities were only significant on about high blood pressure, but again, in a negative direction. Next slide. So this is a brief overview of the qualitative results from the focus groups with the implementers of the CHAPI. So the experience, they described that the experience was overall good. The implementers could really help the residents, they felt. And with training, the implementers felt that they were able to manage the technology and also the different elements of their role in implementing the program. CHAPI implementers also described positively the program positively and said that the clients and they themselves wanted it to continue in the communities. And the main challenge for the implementers was really when they referred residents to the medical doctor or the community resources, there was a lack of supply. That was their main challenge. Next slide.
So basically, in conclusion, we've concluded from this work that CHAPI was definitely very feasible to implement in the Philippines. It was cost effective and it was definitely appreciated by the communities. And the results were good. They were in favor of the intervention, certainly in rural areas, maybe not as much in urban areas, but that's also something to consider as we progress with the program and we scale it up. And what we're trying to do now is we're trying to scale up the program beyond what this trial was and expand it in the whole of the Zamboanga Peninsula. Next slide, please. So just lastly, last mention is that as we scale up, we have a lot of help, partnership and interest from the departments of health in the Zamboanga regions. The Ateneo de Zamboanga University continues to be leaders in this area as we have done some more work seeing how we can potentially scale up this program. Thank you very much.
No, thank you, Rick and Gina, for a great presentation. And I didn't say thank you too much to Rajesh, but yes, thank you to Rajesh too. At this point, I open the floor to anyone who might want to ask a question of the project teams. I think I can ask a question, actually. Gina, Rick, I think you mentioned that actually an aspect of the continuing impact of CHAPP, it sounded as though you are thinking of exploring this in other areas, other countries. Is that correct?
We have very strong partnerships with Thailand, and we have had some discussions about the potential of doing something like this there. But I think actually the model that we're using of how to deliver health-related education, we've taken what we've learned and imparted that knowledge to our Thai colleagues who are kind of using it and adapting it. But yes, we're very open to trying to partner with other countries to for them to be able to run this program. That would be very interesting.
Yeah, and at the start of the development of CHAPP, we had like a working group which included Thailand, Tunisia, Indonesia, Peru. So we have a core group of people who are advising us with regards to how to make the intervention as generic as possible, so that when we transfer the technology to the other LMICs, it wouldn't be as difficult to translate it there.
That's really, really interesting to hear, because one of the discussions that we picked up this morning was on potential generalizability of any implementation strategy, given the fact that you actually might be looking very much to a specific context, a specific setting, environment and culture. So really interesting. Do you have any thoughts on that, Rajesh?
Oh, yeah, thank you, Morven. I mean, and also very nice, Ricardo and Gina. Great to hear the summary of your work. I think very important, obviously, in the context of thinking about scaling out or scaling up, obviously, to take into account potential, maybe contextually specific issues. My one thing that I always am sort of careful about is I don't want to use context as an excuse for providing substandard care. Oftentimes, if you look at the history of global health, they'll say, oh, that context is resource poor, so we're gonna just give them poor quality care. And the one thing I wish all of us to be careful of is that we don't use context as an excuse for substandard quality. And so as long as it's maintaining high quality delivery and maintaining high quality outcomes, obviously it makes sense to take into account some of those contextual differences.
Great point. Thanks, Rajesh. Mariam, I see you have a hand up there, and you found your electronic hand. That's great.
Good evening, everyone. Thanks so much for the presentations. Can you hear me? I don't have a mic. Okay.
We can.
All right. I'm just referring to the CHAPP program. It just interested me that something really simple can be implemented, because we also come from a very low-resourced country. So really would be interested in looking further into the program that you offer. I just wanted to find out, are the sessions rotated? Is the rotation that is presented? How many sessions are within the program that you run?
So it's not really that there's a prescribed number of sessions. It's more that the sessions are drop-in and people can kind of show up. They know that they're at a certain time every week in a certain location, and then people just show up. And really, what we've done in several iterations of this program, whether it's in Canada or whether it's in the Philippines, we've let the number of sessions be driven by the resources that the context has available. So if that region can only support one session a week for 6 months, then that's what the program is, right? If they can support 2 sessions a week for a year, then that's what it could be. So it's quite a flexible strategy, which we have found works very well.
Mm-hmm. And it's ideally we recommend, because based on our RCT results, we recommend a bi-weekly sessions. But it really depends on the resource. What our experience is, because like this is the RCT, we now have the scale up. During the scale up, that was where we wanted it to be more implementable across the province, and that's where the rotation became more crucial. So what we had was we went to different village boundaries. They were very strategic as to where to implement it, because we said we cannot implement it in the whole municipality at one point in time. But what they decided was they would implement in one village, and then after 6 months, because that's the evidence is, move to another village and then move to another village until they cover the whole municipality, and then they go back to the original village. So that's kind of how they are being creative of implementing the session in the whole of the municipality instead of just villages.
However, I will add that in Canada, we have a well-established version of this program, which is actually called the Community Paramedicine at Clinic program, and it's run by community paramedics that we've developed. And it goes into low-income seniors' housing buildings. And what happens is that the populations become so attached to the program, they get very upset when the program has to be rotated because of resource equity, and they don't want it to go. So that's also something that we've now started to consider when looking at scaling up and implementation.
Great, thank you, and good luck.
Thanks, Marvin. I'm happy to do that. To begin, I'd like to acknowledge the traditional custodians of the land on which I'm coming to you from today. And in Canberra, Australia, that's the Ngunnawal and Ngambri people. And I pay my respects to their elders past and present. And I'd also like to acknowledge Aboriginal and Torres Strait Islander people who may be attending our event today. My name's Pat Ridgway, and I am a director at the National Health and Medical Research Council in Australia. And the NHMRC funded 3 projects through the GACD Diabetes Research Programme, and I'm delighted to introduce one of our funded projects, which is a spotlight project on stakeholder engagement in the report, which has already been mentioned. The project, Improving Management of Diabetes in Pregnancy in Remote Australia, aligns to NHMRC's enduring priority to promote wellness and health equity in Aboriginal and Torres Strait Islander peoples' health. It's my pleasure now to introduce an investigator on the GACD project, Associate Professor Renee Kirkham, who joins us today to tell us about the project outcomes. Renee is a Principal Research Fellow and lead of the Diabetes Across the Life course Northern Australia Partnership at the Menzies School of Health Research in Darwin, Australia. Renee is a leader in public health with expertise in implementation science research and qualitative research methodologies. Her team's area of interest is in models of care research, particularly focusing on increasing appropriateness and accessibility of health services. Renee supports a program of research that aims to work in partnership with Aboriginal and Torres Strait Islander peoples to improve health outcomes and break the cycle of type 2 diabetes and related conditions. So Renee, now I'd like to hand over to you, and I look forward to hearing about your research today.
Thank you very much, Pat. That was a very nice introduction. Can everybody hear me okay? Okay, wonderful, thank you. I would also like to, firstly say thank you for having inviting me to speak today on behalf of our team. But before I get going, I would just like to take a moment to pay my respects to the traditional owners of the lands from which I'm meeting today. So I'm based in Darwin of the Northern Territory, and the traditional owners here are the Larrakia people. I'd also like to pay my respects to other First Nations people who may be dialing in to this meeting this evening from where I'm sitting. Moving along, just to give you a little bit of context. So as Pat just described, I'm the lead of this group, the Diabetes Across the Life Course Northern Australian Partnership, but it was founded in 2011 by Professor Louise Maple-Brown, who was the lead CI on the project on which I'm presenting today. Louise is unfortunately on leave, otherwise she would have been the right person to be giving this spiel. But essentially the vision of our group is to work in partnership with Aboriginal and Torres Strait Islander people across Northern Australia, along with primary healthcare and community-controlled health services to break the cycle of type 2 diabetes and related conditions. And I think that it's really important for me to flag that, particularly when we're talking about different stakeholder engagement and how critical that is to the work that we do. We have three major priorities in our program of work. The first is in prevention and improved management of obesity and diabetes across the life course. The second is strengthening community engagement in a life course approach to diabetes, with a particular focus on preconception, pregnancy, and then more recently we're working in the youth type 2 diabetes space, which is really important for our Northern Australian context. And the third priority is to strengthen the Aboriginal and Torres Strait Islander community-based workforce in diabetes. And I think the really important thing to flag here is we're not just talking about the health workforce, we're talking really about how important the community-based workforce is. So it's just critical, I think, to make that differentiation there. I think just really important to flag, I've just spoken about our life course approach, and the project that I will be talking to you about today goes across preconception, pregnancy, and then the postpartum period. We have a number of multiple projects within our broad program of work in the partnership that fit broadly within the different categories of developing knowledge, prevention, and then implementation. And this program that we were fortunate to be funded through GACD definitely fits within the implementation theme. So to give you a little bit, for those of you who don't know our Australian context, we work across a really large area. This particular project that was funded worked across the top end and Central Australia in the Northern Territory, as you can see in the middle of that map, and then as well across in far north Queensland. So really expansive landscapes, and a lot of our Aboriginal and Torres Strait Islander women live in the remote context across these regions. And the care that is delivered is predominantly through the primary healthcare system. So it's a little bit different to what you may experience in other areas of Australia, but it's really important to note, because the primary healthcare system is predominantly who we work with, including the Aboriginal community controlled health services. I think also important to note is that in one of the recent publications that have come out of this work, which was undertaken as a part of Dr. Diana Mackay's PhD, which was recently published, and I'll speak about it today, was that of 7,000, just to add some context, of 7,000 births per year, in the Northern Territory, 18.6 of those, and in far north Queensland, 20% of those were impacted by diabetes in pregnancy. So we've got really high rates for our minority population. So that leads me to this project. This project was really developed off the back of previous work that we had done, and we knew that to improve systems of care and services for women with hypoglycemia in pregnancy in our context, there were 5 key things we really needed to do. It was the recommendations were around the need to increase the workforce capacity, skills and knowledge to improve the health literacy of women, to improve access to healthcare through culturally and appropriately clinically appropriate pathways, to improve our information and management communication, to enhance policies and guidelines, and to embed a clinical register for women with diabetes in pregnancy within our models of care in both the Northern Territory and far North Queensland. And so these, what you can see on the screen, they're some of the approaches in which we took to try and address those 5 recommendations that had come from previous work. So what I'll report on today is, as I said, a mixed methods study that came out of the broader evaluation led by Diana, really exploring the impact of this multi-component intervention from the perspective of health professionals. So that involved a survey and interviews, and with clinicians, policymakers, and also the implementation team. I'm just looking at the time. I don't have much time left, so I better speed along. Yes, moving on to stakeholder groups. I think what was really important to note is that we, in the partnership, we do engage, and this study particularly did engage with a number of really critical bodies and stakeholder groups. So clinicians, we had an Aboriginal and Torres Strait Islander advisory group, which provided a lot of input and guidance around the study design and understanding and interpretation of findings as they were relevant to our community groups. We embedded a lot of local and national policymakers within our steering committee, which was quite a powerful mechanism in terms of translating different findings into practice in a timely manner. And we had a lot of advocates within our steering committee and other partners that were able to implement different strategies, as I said. So the Chief Health Officer was one of those key people who was able to translate our findings into practice really quickly. Sorry, I was just reading the message. The methods of engagement, I think this is one of the key strategies that we use across all of our partnership work, but really embedding investigators, members of primary healthcare within our decision-making processes. I think that's really important when you're working in remote contexts across Northern Australia, but I'm sure many of you would relate to that as well. Moving along, sorry, I'm sort of going quite fast now because I'm conscious I'm running out of time. One thing that we do know is that, of course, engagement is really resource intensive, and one of the major challenges that we have in our remote context is high clinician turnover. And when we were working with clinicians in terms of implementing some of our new strategies or asking people to adhere to different referral pathways or other interventions that we were implementing, it's really hard when you've got I think last year it was 160% turnover of nurses in our remote primary healthcare setting. So you have to think about sustainable strategies that outlive the individual health professional. So we've definitely been working on that, but also know that the importance of really harnessing those relationships that we have with key people and champions across the North is incredibly important and critical to all of this work that we do. So some of the thanks, Izzy. I'm just conscious of how slow I'm going. So some of the benefits that were outlined through the qualitative component of this work highlighted that health professionals did feel well supported in providing care through the networks that we were able to establish and really nurture throughout the course of the work. They reported an increase of support as a result of some of those intervention activities. And also they really valued being able to access different relevant support which facilitated a more women-centred approach. So for example, we were able to link primary healthcare clinicians with different specialists who would be based in the tertiary centres, so whether it be Alice Springs, Darwin or Cairns Hospital. Thinking about our foundations for the future, so this study definitely assisted with creating some of those networks and different mechanisms for supporting antenatal and postpartum care for these women, but we also recognise that we do have ongoing work that we need to be doing in terms of developing culturally appropriate resources, educational resources for women across the Northern Territory and far north Queensland. But what's really exciting is that this work, this particular project, actually did inform another recommendations for another study in which we were successful with obtaining funding for, which is doing exactly that. So that's a really good outcome, I think. And the last slide, I can say, yeah, thank you guys. And I think that some of the core lessons which we've taken from this work, which were outlined in the previous talk or the report, was that collaborating for success, tailoring to the context, technology being used as a tool but not a silver bullet, particularly in terms of our clinical register, and the need and appropriateness of addressing health equities within our project and our broader program of work are absolutely critical.
Thanks very much to Renee for describing your project, and to Pat for introducing the project at the outset. We'll move straight to our next project, and then there will be time for some questions. And so I'm going to invite Carolyn. Do you want to introduce yourself and our next speaker? Thank you.
Hi, yes, I'm Carolyn. So I'm the Programme Manager for GACD, and I have the pleasure of introducing Ed Fottrell today. So Ed's a Professor of Epidemiology and Global Health at University College London, and also the Director of the UCL Centre for Global Non-Communicable Diseases. And Ed's work involves research into maternal, neonatal and child health, non-communicable diseases, community interventions and M-Health, so really quite appropriate to this research programme. And today, Ed's going to talk to us about the impact of the Bangladesh DMAGIC trial, which used a cluster randomized control trial to evaluate population-based interventions to prevent and control diabetes within rural communities in Bangladesh. So over to you, Ed, and thank you so much for joining us.
Thanks so much, Carolyn, and congratulations to you and the whole team at GACD for putting together this incredible report. Hopefully you can hear and see me okay. I'm having slight tech problems, so I'll just ask that you kind of click through the slides as we go. So thanks, and thanks also for the opportunity to share some of the impact from the DMAGIC trial. So this is a project between UCL and very long-standing partners in Bangladesh, the Diabetic Association of Bangladesh, the Centre for Health Research and Implementation. And we ran this project, the Diabetes Mellitus Action Through Groups or Information for Better Control, DMAGIC, where we worked across 96 villages in a rural area of Bangladesh to test two separate interventions. So we tested M-Health interventions and community mobilization. If we can click to the next slide, please. We did do quite a lot of formative work in preparation for DMAGIC. We spent about 8 months doing formative work to really understand the context of Faridpur, the area that we were working in. And in this context, we found it's typically rural, I suppose, for Bangladesh, but there's availability of fruits and vegetables, but huge availability and accessibility to unhealthy foods and drinks and snacks. A lack of diabetes knowledge and awareness, which I'll speak about in a moment, but also a lack of availability for diabetes screening and diabetes specialists. There's a trend for people to shop around for care, and distance to reliable diabetes care made it inconvenient and costly to access, usually people needing to be accompanied by family members as well. And there was a lot of non-adherence to medication for people living with diabetes. Also, we observed in our formative work about the role of physical activity, but also very much gender-based roles, and a very patriarchal society where women were not expected to be outside the home on their own. They were not expected to be doing physical exercise or activity, and that men are the busy people. Men should be the ones outside being busy providing, and that they should be providing, not playing games, so not doing sport or physical activity for for leisure purposes or any other purposes. And also that women had the cooking role in the household, and there was an expectation of salty, oily, sweet food to be prepared. So that was more kind of the qualitative contextual understanding. If you click to the next slide, please. We also did a pre-intervention cross-sectional epidemiological survey in a sample of around 12,000 adults aged 30 plus. And the key findings from this were that about 30 to 40% of adults in this age group had raised blood sugar. So they either had intermediate hypoglycemia or diabetes. And we tested that with fasting and 2-hour OGTT or glucose tolerance tests in the population. Amongst those who had diabetes, about 10% of the population roughly with diabetes, 2/3 were unaware of, actually more than about three quarters were unaware of their diabetic status. And so, we had a huge burden of diabetes illness, but actually very little awareness and reflecting again the limited opportunities for screening and diagnoses. We also observed high levels of raised blood pressure and just a very high burden of NCD risk in general. So of common risk factors, more than 70% of the population had 3 or more of those common NCD risk factors, including inadequate physical activity, inadequate fruit and vegetable consumption, and certain behaviors such as tobacco use. Please, next slide. So we did then conduct a cluster randomized control trial to evaluate these 2 interventions, which I'll speak about in a moment. And it was a cluster randomized control trial, but it was also had a very, very strong emphasis on process evaluation. So throughout the entire process of the development of the intervention, the implementation, and subsequently, we had really rigorous, mainly qualitative, but also quantitative process evaluation, as well as economic evaluation. The photos that you can see here are just of some of the community engagement that we had to do. So as I say, we worked across 96 villages. That's a lot of people. And throughout the whole process, needing to engage with community leaders and other stakeholders, but also to try to help them to understand what we were doing in terms of a randomized control trial. So we did a public randomization so that after consent, community leaders were able to understand why maybe their villages were not receiving interventions while others were. Next slide, please. So the first intervention that we delivered into 1/3 of our villages, so 1/3 of the study areas, was an mHealth health promotion intervention. And this was developed based on our formative work and using behavior change theories to really design a voice message delivered intervention to people with mobile phones for them to understand and learn more about diabetes and to model certain behaviors that might reduce the risk of diabetes and might reduce complications if you do have diabetes or help you to control your diabetes. We've written about and spoken lots of times about how we develop these messages and the processes in doing so. And ultimately, we developed 122 messages, which were sent twice weekly across over 9,000 subscribers in 1/3 of our 1/3 of our study villages. So it had a very high coverage rate. And these messages included information giving, but also lots of dramas and songs and different ways to model certain behaviors and convey information. Next slide, please. The second intervention was community mobilization through a process called participatory learning and action, or PLA. And this is a group-based intervention led by lay facilitators, and it's open to everybody in the community. So it's not just people living with diabetes or at risk of diabetes, although they are particularly encouraged to attend, but it's for all members of community. And we had separate men's and women's groups, as that was appropriate in this context. And these groups led by lay facilitators, so these are people that were recruited locally and trained in how to deliver information, but also into how to enable kind of engaging participatory discussion, led these groups through a 4-phase cycle, which you can see on the right of the slide. And this 4 phases involve first communities sitting together to understand and learn a little bit about diabetes, but then for them to look at their context and see what are the things in their context that are causing people to become unwell, and to prioritize what are the things that maybe they could take control of and they could do something about. So then in the second phase, the community plans together a number of strategies to try and address the threats to their health. They implement those strategies, and then they go on to evaluate and reflect on how those strategies have been working, and they progress through this cycle of PLA. Next slide, please. So the strategies obviously vary depending on the context and the communities and what they saw as a priority, but some of the common strategies that came across were communities organizing to arrange screening in their communities. So they took it upon themselves to pool funds, to find resources and bring people to their community for blood glucose testing. And they also recognized a lack of physical activity as a threat to their health and a lack of opportunity for physical activity. So we know that men's groups established walking clubs, there were swimming competitions. And as I mentioned earlier, women, there were huge social barriers to women doing physical activity. And these were really effectively addressed by many of the groups where women consulted with men and addressed these issues. And again, managed to somehow change a context where it was acceptable and encouraged, in fact, for women to exercise in groups publicly. You can see the bottom left, there's also initiatives for community gardening, kitchen gardening, to create or to provide better access to fruit and vegetables, and also large, bit wider community meetings. So typical PLA group meetings are maybe 20 people meeting at a time each month over about 18 months, I should have said. But during that process, they also engage with the wider, other members of the community who don't necessarily engage regularly with the PLA meetings. Next slide, please. So very quickly then on the impact on this, what we saw from these different interventions, again, evaluated in our cluster randomized control trial and evaluated in a random cross-section of the population. So we didn't look at, did the intervention improve health for those individuals that really actively engaged? We looked at, is doing these interventions in a community, does it change the population level health indicators? And you can see that in terms of knowledge and awareness of diabetes, both mHealth, which is shown in yellow, and PLA increased population knowledge and awareness. So I think mHealth itself on its own was very effective at increasing the population knowledge and understanding, but doing so through a community engagement mobilization method was much more effective at increasing knowledge and awareness. Next slide, please. And then the kind of the big headline findings, I guess, in terms of impact, was about what did these interventions do to blood glucose, to diabetes. For mHealth, we didn't see any difference in the prevalence of intermediate hypoglycemia or diabetes at the population level compared to control. But for the PLA, we saw absolute reduction of over 20% in the prevalence of intermediate hypoglycemia and diabetes, so over a 60% relative reduction. We also looked at the incidence of diabetes, the 2-year incidence in people living with pre-diabetes at baseline. And again, we saw that mHealth didn't change this incidence, but the PLA community mobilization had a huge notable effect over the 9% absolute reduction in the 2-year incidence. As I mentioned, we did cost effectiveness analysis. We saw these interventions to be highly cost effective. And we also saw that they were equitable, that all members of the community in terms of wealth, education, and gender were benefiting. Men and women were benefiting equally. And the poorest, more marginalized members of the community were benefiting from the impacts of this intervention. Next slide, please. The process evaluation really allowed us to try to understand how that PLA works. Again, we've written about this and I'm always happy to talk more about it, but essentially what we feel is that this group intervention, through increasing individuals' health literacy and community health literacy, improves opportunities for individuals to be more healthy, whilst also addressing the social and contextual barriers that might be stopping them from being healthy. So we call it kind of enabled individuals within enabling social contexts. Next slide, please. So just to finish, following DMAGIC, we went on and we've done the Declare project, which was a scale-up study where we were looking to evaluate the impact of PLA, the group intervention, at scale, to look at urban adaptation and to look at different ways of modifying the intervention for greater sustainability and even greater cost effectiveness. And those results can be reported at another time. And final slide, please. We've also very pleased and honoured to have received one of the GACD cities bids recently, where we'll be looking at the PLA process and adapting it to urban communities against not just diabetes, but NCD risk in general in Nepal and Bangladesh. And again, please watch this space. So thanks everybody very much.
Thank you both, Renee and Ed. A bit of a virtual round of applause for giving us a very brief taster of your project spotlights. We have got not that much time, but I will just open the floor to see if we have any questions. If there are any questions, please raise your electronic hand. It's probably more effective than your real life hand. Or put your question in the chat. Let's see if we have anything. While people are maybe thinking, I just did want to say, Renee, it was really interesting. You were telling us about the challenges of working in a very remote rural area, and that you have a very high turnover amongst your clinician, your healthcare providers. And you mentioned that you needed to ensure that you had sustainable strategies. Can you just sort of give us a brief snippet into what those sustainable strategies might look like?
That's a really good question. Thank you, Morven. And I knew as soon as I said it that somebody may pull me up on that or to know a little bit more. So I think some of the strategies are around including recalls, like necessary recalls in some of our primary healthcare systems. Also ensuring that, so it's electronic pathways really, particularly in referrals, making sure referrals through the antenatal period and also through the postpartum period. Often women, in our context, they have to come into the tertiary centres to have their babies and then they go home. And so often the discharge summaries don't always transfer back to their local clinics. So really working with some of the systems there to ensure there's that continuity and the communication between different health service providers, are considered. Yeah, that's one very brief example, Morgan.
Great, thanks very much, Renee. Yes, it's interesting how forms of digital technology are being sort of incorporated. They might not be the be-all and end-all, the silver bullet, but incorporating them can be really effective ways forward. Great, Bindu, I see you've got a raised hand. Please go ahead and ask your question.
Thank you, Morven. This is a question for Edward on the participatory learning action model that you used. So we have a life course approach project in Fiji evaluating the health promoting school. So we're doing a mixed method process evaluation of the current health promoting schools, and then we're having 6 months of something like the participatory learning action framework. We haven't fully planned it yet. But one of the things is taking the findings and working with key government stakeholders, as well as those on the ground, both community as well as school. It's more about recruitment and the participants from the community and teachers. How were you in your program of work? How were you able to recruit the participants?
Thank you. Great to hear about your work. I'd love to learn more about that. Recruitment. So this work with diabetes was following on from years of work that we've been doing with the same approach of PLA, participatory learning and action, with focusing more on maternal and child health. So we'd had quite a lot of experience of how to engage women in this type of intervention, and a lot of learning from that, which we then actually brought here. So here we had, given the context of Bangladesh, we felt it was more appropriate for separate men's and women's groups. And so we were actually quite worried about how will we get men to meet and how can we run this. And so thinking carefully about who was facilitating these groups was important. So that kind of level of credibility and, is this something people should come to, and would they want to come to it? Being flexible about when meetings happen, and recognizing that, these groups, the idea of all of this is that they should belong to the community. So for men in particular, they couldn't meet during the daytime. They wanted to meet in the evening. So we had to kind of allow for that flexibility and accommodate that. We also engage a lot with religious leaders. So and not just religiously, but community leaders in general, but religious leaders that were very influential, and getting their kind of understanding and their buy-in to the intervention, and that kind of stakeholder engagement from the very beginning was essential, because they then became champions for it, and we're encouraging people to not just for them to go, but to getting people to encourage other people to go as well. And then also back to the facilitators. So these facilitators were recruited locally. And so again, they weren't health professionals. They had some basic training from us in how to do group facilitation, but they became really important in convening the groups. And so they started to kind of, before we'd have meetings, would go around the community and kind of knock on doors actually, and say to people, do you remember that this is happening in a couple of weeks' time or next week? Please, can you come along? And then I think the final point again was just to say that the groups were open. So there was no kind of, they were in a public space. They were it was up to the community how and where and when they did that. But it was clear that they're not patient groups. They're not for people living with diabetes only. They're not for people living with the disease. And I think that's quite important. And it was one of the reasons we think it was so effective, was that it was addressing not just those individuals, but the context and the other people who influence those individuals' health. So there's lots of different strategies I think that we applied, but I guess the take-home would be engagement, stakeholder engagement, listening, and designing in a participatory way.
Thank you. That's useful. Thank you so much.
Lovely. Thanks very much. I'm conscious that we really do want to hear from our panel, so which is our next session. So I'd just like to say thank you so much to Ed and Renee for taking the time out in their day, whether it be at the end of their day or at the very beginning of their day, given where you are both situated, for coming along today, joining us, and to give us a flavour of your project spotlight. Of course, everyone can read much more about your projects within our report itself, which has now gone live on our website. So just thank you so much for taking time out to join us for this particular session. Okay, at this point, we will invite our panel to take the metaphorical chair, let me say. We will have Gina Agarwal, who we have already been introduced to on our panel. But the other panel members, I'm going to invite Maria Lazo Porras from the DM14 study, based in Peru. I think you're still there. Great.
Yes.
And Jennifer Mangola from the WHO. That was a quick roundup, but actually I'm going to give you each a little time to introduce yourself more thoroughly to the audience. Let me say with Maria, first of all.
Hi, everybody. My name is Maria. I am based in Peru, and I am part of Crónica, so it's a Center of Excellence in Chronic Diseases. I'm happy to be here and share with you the findings of this report.
Thanks, Maria. And Jennifer, Jen.
Thank you. My name is Jen Manny-Guler. I am a technical consultant to the World Health Organization's Diabetes Unit and the Department of Nutrition and Food Safety as well. I'm also a physician scientist based in Boston at Harvard Medical School, and I'm excited to be joining today.
Thanks, everyone. And Gina, I won't ask you to introduce yourself again. You got a really nice introduction earlier in the session. I think we'll get our audience a little bit more engaged again by asking them one of the Menti questions again. So to ensure that people are keeping in touch, keeping stimulated, and we're going to ask the audience, what aspects of diabetes implementation research, where are the gaps that remain in implementation research? I'm going to turn perhaps to, I'm looking at the big blue glaring awareness. Gina, how aware were your communities about their diabetic status? Is this a remaining key issue?
I mean, I think people are becoming more aware. I mean, certainly in our communities, I mean, I think that even though they may be aware, I think the problem is that people are just too busy with everything that they're doing and life and trying to, you know, earn an income and do whatever they're doing, right? So, I mean, I think awareness can be a problem, but I think awareness in context of everything else that they're doing is the problem, right? Like prioritizing that awareness, like where does that awareness of health related issues and diabetes, and specifically, where does that get placed in people's everyday, you know, living their life? I think the healthcare providers are obviously very aware of this issue and of diabetes, and I think
we had the issue where healthcare providers were so aware, the Department of Health was so aware, they had bought this chunk of medication, diabetes medication, but although they were so aware of diabetes and they had this stockpile of medication, what they hadn't thought through was how were they going to actually identify the individuals who could get the medication. So that was really sad, because then a chunk of medication actually ended up going to waste and not being used. So I think awareness is a problem, but I think it's a differing problem in healthcare providers versus populations. And I think prioritization is a big factor in that.
Maria, do you have any thoughts on awareness amongst the populations you were working within?
Yeah, I think that similar to Gina, and also if we consider that these chronic diseases, you don't feel anything until it's very late. So people can still work and they can still live in their daily life until it's sometimes very late. Because this is not a priority, so it's very difficult too. And in terms of healthcare workers, I think that in urban areas, they are more aware, but in rural areas, sometimes not. And if we add the limitations for have an adequate diagnosis, this is even more problematic. So I will like to raise these two issues.
That's, yeah, really interesting. Jen, I ask you the same to reflect on awareness.
Yeah, I mean, I think awareness is at the core of the diabetes, the Global Diabetes Compact, which I'm sure many people on this call have heard about probably extensively. So at WHO, we're talking a lot about how to frame diabetes care and including implementation, which I think is at the core of what's really needed most around the WHO's global diabetes targets. And so in terms of awareness, the goal is that 80% of people in the world with diabetes will be diagnosed. Probably many of you saw that this morning, actually like at midnight last night, Eastern Standard Time, I got the release of the new diabetes estimates. And between that and the initial target setting papers that have been published by WHO colleagues in the Lancet, we know that now more than 800 million people in the world probably, we think, have diabetes. And this morning, we know that probably less than 60% of them are currently being treated. And we think in many parts of the world, in many regions, only about half of people will be aware of that status at any given moment. So I think that awareness and the concept of awareness and diagnosis is the first step in helping people move through the care cascade or care continuum. And so it's at the core of the goals that we all have in the context of the targets.
And really interesting to consider if it's both the communities, the patients, the users, but also the healthcare providers, that actually awareness raising, the implementation strategies that are deployed to encourage that awareness may be very relevant, as we heard earlier. What benefits did you find, if any, from being part of a program rather than being an isolated project on diabetes? And I guess that's particularly going to Gina and Maria. Did you see yourself very much isolated, or were there learnings that you got from the GACD Research Network which helped?
I can answer for that. I remember going to some of the early meetings, the annual scientific meetings, and thinking when I had heard some of my colleagues speaking about the diabetes programs, I remember thinking, wow, we're having the same challenges and the same issues and the same barriers when we're implementing, our program. And I remember sharing, I think one of the presentations we actually did, like one of the streams, was talking about barriers in diabetes care. And I think I talked about how challenging it was for us in a hot climate to use a portable A1C machine. And I remember lots of other people commenting about, yes, it was challenging and they had done this and that to overcome it. And I certainly found it quite useful and interesting to realize that the challenges that we had were not unique to our setting, but actually other people and other programs and projects were going through very similar things.
Right. Maria?
Yeah, and also I think that we learn a lot in these working groups where we were trying to like bring different experience from different regions to try to standardize some aspects related to diabetes or to implementation science. Also in the project that I had that it was about health, like it was a big opportunity to learn about these challenges, but also solutions, like how we can solve these different problems that we had with our populations that were similar in other countries. Particularly for me, because I was in a very early stage in my career, it was a lot of learning from other researchers, from other low middle income countries and high income countries. So I think that we win a lot with this network and with this sharing experience during the process.
Great. Catalina, I think I saw your hand go up, but did you have a question? Hi.
Yeah. Hi. It's so exciting to see everybody and listen to all the projects and understand, building on Gina's comment, how similar we are, what with all our differences we think we have. And I'd like to congratulate everybody, and I'd like to congratulate the team who pulled together this report, because it's really amazing how well I think it reflects what we did in those 14 research projects and all we achieved. But so I'd like to just ask one question and one recommendation. One to Gina and to Maria and to Jen, is how much we need to study more issues around culture, because many things are very similar in context. Many things are very similar in the medical care. We have the problem with medications. We have the problem with is the health personnel aware? But I find that maybe where we would find differences and where we need to work perhaps is looking at what idea people have about prevention. Because one of the big issues with diabetes is that they say, well, they told me I had diabetes, but I don't feel anything. I don't feel pressure. I don't have any pressure, referring to blood pressure. I don't have any. And then all of a sudden somebody says, well, you have diabetes and you really need, to go to the doctor. How can we get work on cultural issues around prevention when people are just trying to live 24 hours at a time and they're not thinking down the road? I think that is cultural, and I think it has a lot to do perhaps with our rural and urban differences, because in a rural area, we can see further, I believe, because we're closer to nature and we see all those changes. I don't know. I think we have to, this is an issue that we should look at and related in our experience to diabetes and more preventive care. And the second maybe recommendation or question I'd like to make is how can we take advantage of all these relationships and all this work and all this tremendous, amazing amount of coordination and collaboration across, what did you say, more than 80 countries, for people like in our research team in Northern Mexico who have not continued with funding and who have not continued responding to the calls in GACD, but who we would really like to continue in contact in some way. This has been perfect, because I remember all the discussions we had with Gina, for example, or with Maria, and I go, oh, this is so useful, because this is what we're facing right now. Our whole health system has been, first we had the pandemic, and then we had a new federal administration and a restructuring of all the health systems. So we had to always be running after all of these changes. But I believe that other countries have probably faced the same thing. And I go, oh, I wonder how they did it here. I wonder how they did it there. So I know you're overwhelmed with work. I know you have new calls all the time and you're integrating new people, but I'd be interested in seeing how we could have a, I don't know, a yearly Zoom call with a older generation of GACD fellows. Thank you very much.
Thank you, Catalina, for those comments. I think, yeah, in many ways, we see the current report really just as a springboard. Often impact takes a very long time. It's not been that long since our projects actually completed. And I think their impact is only starting to emerge. And as we build on that with some of the other activities we have in diabetes, including within our scale-up call, within our life course call, within our Healthy Cities call, potentially the evidence will grow. And yes, absolutely, we can call people together. It's a really nice way of bringing out some of the collective ambition for researchers and project teams. Gosh, I won't talk. I see Josephine has also got her hand up. Maybe we can be quite quick because I see we're getting to the end of the time frame we'd set aside for this. But Josephine, please.
Oh, no, then I will be very quick. I think over the years, the GACD calls have become better also in making the connection between implementation and research. I was also part of a diabetes call, and there we had no specific implementation partner, or well, partly, but a lot of the implementation design and doing the implementation we did ourselves, which was also a disadvantage, I think, because it took up a lot of resources. And also, for instance, meant that we had to, for instance, fund part of the medications for diabetes ourselves, because in Uganda, for instance, this was not part of the routine package. Whereas in the newer calls, scale up city, there's much more emphasis on already very early partnering with people who implement, who can sustain, and that has led to much more intersectoral consortia, I think, with not only research partners, but implementation partners. And yeah, positive, but also extremely necessary, because sometimes the questions and the challenges are more on implementation, whereas these are implementation research calls, and that differentiation pops up now and then, but it's good to keep sharp yeah, on all our eyeballs, I think.
Yeah, I think it's a very pertinent. We are trying to improve. I think it's also the field of implementation research is maturing. So people are becoming more familiar with it as a field. Maybe methodologies are improving, and certainly we see that partnerships are an essential ingredient. The stakeholder engagement is essential to have sustainable outcomes. And for this panel, we have invited three very different participants to form our panel. And the first thing I'm going to do is to invite each of them to say who they are, where they're joining from, and their affiliation, and maybe just, give us an inkling as to what sparked your interest in diabetes implementation research. So let me start with Johan.
Good morning, good evening, good afternoon, everyone. Yes, I'm based at the South Africa Medical Research Council in Cape Town in South Africa. I'm been representing the MRC for the last since 2013 on the program subcommittee. And yes, I'm basically in not really into implementation science, but I mean, since I joined the GACD, of course, I got very attracted to implementation science. And I think for me, one of the things I do feel this diabetes as implementation researchers underscore the importance of the cultural tailored different interventions and also the patient education and the community-based support. And I think we've heard some of this morning again. So yeah, and I think moving forward, for me, one of the important areas will be precision medicine that could also play a role. And I think I'll stop there. So for Bianca and Anushka to introduce themselves too. Thanks, Morgan.
Thanks very much, Johan. And I'll now turn to Anushka. Do you want to introduce yourself, say where you are, and your interest in implementation research for diabetes?
Well, thanks very much, Morgan, and good morning, good afternoon, good evening to you all. My name is Anushka Patel. I'm the Chief Executive of the George Institute for Global Health. I'm joining this call from Sydney in Australia, from the lands of the Gadigal people of the Eora Nation. It's really a pleasure to be here. So I've had a career that's combined research and being a clinician as a cardiologist. And I guess I don't have anything that sparked my particular interest in diabetes implementation research, but I've very much had a spark and interest in implementation research in chronic diseases from my background in both research and as a clinician. My research career has very much been, prior to this, focused on safety and efficacy trials of new drugs or new ways of using old drugs for the prevention and management of chronic diseases, particularly cardiovascular diseases. And one of the biggest trials I led was the ADVANCE trial, still the largest trial of blood pressure lowering and glucose control in type 2 diabetes. But at the end of the day, a level of frustration, I guess, that while these sorts of trials have influenced guidelines and do influence practice, there are large gaps. I saw that in the research we did looking at implementation gaps, but also in my daily practice as a clinician. So that really pulled me into implementation science. And I've had the good fortune of either leading or being part of teams in 4 rounds in the GACD funding, which is fantastic. I've been on a steep learning curve during that period, still on a learning curve. And thank you for the presentations we've just heard, adding to my learning curve. And thank you for inviting me to be part of this panel.
Thanks very much, Anushka. And finally, our third member of the panel is Bianca. Do you want to introduce yourself, Bianca?
Thanks a lot, Dr. Roberts, and thanks a lot for all of you celebrating World Diabetes Day with us and this important agenda. My name is Bianca Hemmingsen. I have the technical lead for diabetes in the World Health Organization. And needless to say, implemented research is really key. We have so much evidence based on clinical trials, as Dr. Patel correctly said, of what should work. But still, we see, for example, now the prevalence of diabetes is skyrocket high now with more than 800 million. Like Dr. Roberts said initially, we know how to prevent diabetes in theory, but how to translate it into policies and practices, that's really a gap. And even not only prevention is a problem, also management of diabetes, despite having evidence-based guidelines, there's still a huge gap on how to make these interventions available and feasible in settings. It was alluded to by Dr. Futrell, but it's also shown in our data that about 60% of people with diabetes that are 30 years or above, they do not receive any treatment for diabetes. So there are several gaps we have to address. The evidence is one thing, but the real world is for sure another thing. So thanks a lot, Dr. Roberts.
Thanks so much, Bianca, and thanks everyone for just your initial comments. I mean, I think they reflect some of the key areas of interest for implementation research. Now, this is very much a panel intended to be audience participation discussion. And I think we want to ensure that our audience are still with us and engaged. And I think we're going to run another of our Menti interactions such that we can see what are your thoughts and thinking before we open the floor for some questions for our panel. So Izzy, I think you're going to lead us again on the second Menti adventure.
So the question here is just a word cloud. What do you think are the major gaps in diabetes implementation research at the moment? What needs addressing? What needs attention?
Great to see some of the points coming through. Interesting major gaps in diabetes implementation research being political goodwill. Yes, very much the pulling from the sort of policy making side, how to engage policymakers with the fantastic research outcomes that we might have. How does this actually come through? I think the awareness potentially there is around people's own awareness of diabetes. We had heard from Ed that that was a significant problem in Bangladesh. He said something like 3/4 of the populations he was working with were unaware of their diabetes status. Just giving it a moment to see what is coming through. Scaling up, definitely a point there. It's really interesting for GACD that, yes, we have had a call for diabetes projects themselves, and then a few years after that did have a scale-up call. Those projects are frequently still ongoing, but scale-up and understanding of scale-up is critical for knowing about implementation. Okay, so I think we've given enough time to build ourselves a bit of a word cloud there. I'm going to ask Anushka, while you're still with us, is there anything in this word cloud that would spark a comment from your perspective?
Yeah, absolutely, Morgan. Actually, as the awareness word lit up there and grew in size, I mean, there's a number of ways you can look at awareness. One is around awareness of communities and individuals who are impacted by diabetes or at risk of diabetes. But the other broad awareness area that I've noted is the whole area of implementation research, awareness that implementation is actually requires a scientific approach, is a science. There, from policymakers, from funders sometimes, from other researchers, you know, there is often an attitude, well, we have the evidence, I'll just go and do it. And the complexity of implementation is often you know, under-recognized. And I think this is a fantastic contribution that GACD has made across these various areas.
Thank you for that comment. I completely agree, and I'm sure you're building on your experience of undertaking a number of clinical trials which provide that evidence for this thing can work in a particular setting, but actually, why is it not working when we try to roll it out into a real life setting, which is perhaps somewhat different to where the original trial was undertaken? Bianca, I don't know if you wanted to follow on with a comment from that.
Oh, yeah, thanks a lot, Dr. Patel, for your insights. And I completely agree. The translation from evidence into real life is very difficult. And I will say something that is often missing when you see a study and people say, oh, this worked, this should be implemented. It's the lack of focus for the context-specific solutions. Because even though you have one solution that works in one country, it doesn't mean that the same solution works in another healthcare system, in another setting, in another country. So I think this knowledge about the content specific or regional specific, context specific understanding is very important. And of course, other things that are also important is the long-term outcome data often are not really well known in the clinical studies. They often have a very short duration of a month, maybe a year or two. It's very rare with long-term studies, but here we actually, if we do it systematically, have a chance to see how it works in the longer run. I think that's some of the things I want to say, but especially also regarding awareness. I think awareness, especially of diabetes, is really lacking. I don't know where the lack primarily is, but we can see for the huge treatment gap that we have, it's mainly driven by people not knowing they have diabetes and therefore not being treated. So hopefully awareness could be a thing through public health campaigns maybe, but it also needs buy-in from the politicians. It needs to be prioritized from governments. And with that also come financial priority, right? Thank you.
Right, and that's a really nice segue into Johan. Maybe not necessarily how big a financial priority is implementation research on chronic diseases, but maybe different ways of funding. Johan, what do you think is the benefits of the work such as GACD, where we have a number of projects all working around the world, however, on diabetes? But to you as a funding agency, are there benefits from that kind of work stream?
Sorry. Thanks, Norman. Yes, of course. I think for me, speaking from the South African point of view, of course, I think the GAC Alliance has been very, valuable in the sense like our partners joined the MRC and funding specifically, different implementation science proposals over the last 13 years. That's the one thing. I think the other thing that's also very important for us that we've learned, which was a outcome with our planning, it was the network that the fund has built over the last 13 years. I think for me, what was nice every year when you go to a meeting and you speak to the actual scientists who are, the recipients of funds, to see how they actually also have combined and applied at different funding agencies. So that grow the implementation science community across the world. I think for me, that is something that GACD should always be very proud of in doing that. I do feel also by doing that, we can share a lot more because funding is getting less and less. Let's be very honest. I mean, if you look around the world, so that is very important to share our knowledge. And also, I think what Bianca's touched on also, it's not just different countries. I look in South Africa, we have 9 provinces here, and the health systems in the 9 provinces are very different. So it's not one size fits all. I mean, what works maybe in one province definitely doesn't work in the other 3 provinces. So we as scientists should also be aware of that when in planning our projects or proposals, that you get the buy-in from across different provinces and not just in one area. And I think that's for me one of the sort of things I've learned over the last few years. And the other thing, of course, we all know is the policymakers. I mean, it's no sense we as scientists have this wonderful ideas and have all these wonderful plans, but the policymakers are not really interested to implement it. Then why are we doing it? So I think we've learned over the years, and it's country specific. But, I can only speak for what happened in South Africa. And I can say that we are building a closer relationship between our Department of Health and the different health departments between the different provinces. And that is very important. Thanks, Morgan.
Right. Thanks, Johan. I see that we actually have started to get some questions coming in through our chat box. And I see that there's a question about actually Diabetes World Day and risk calculation to try and encourage people to know their individual risk. But there seems to be some disparities between some of these risk tools. Does anyone want to share their views on that?
Perhaps I can make a comment, Morgan. I think that's it's a good question and a real issue, and I think it also sheds a light on the reality that implementation science doesn't occur in a vacuum, and that it's not a linear process. And in fact, the outcomes of implementation research can inform the more discovery type of research as well. It can be circular. So, for example, this sort of issue that you discover when you try and implement a tool or a series of tools in a community, you identify there's discrepancies between tools and the outcomes, which leads to generating more evidence about the effectiveness of tools. But also you recognize, I think people who've worked in the space have also recognized that people's perceptions and interpretation of risk is very different. and how you communicate that and how you utilize that in implementation strategies is also generates further questions around implementation science. So I think it's an ongoing cycle of evidence generation that's required here.
Thank you for that comment, Anushka. I think there's an interesting discussion building here around the need for context-specific understanding of the implementation strategies that might need to be adopted to ensure that you get real-life rollout. There's possibly going to be always that balance, because we can't necessarily narrow down to every single specific context. And I think that's potentially one of where we see one of the interesting areas in trying to look at 14 projects taking place around the world and seeing if we can actually bring out certain trends or commonalities amongst the implementation strategies, despite there being very different contexts. So I think perhaps that's what we need to aim for. We're perhaps never going to be able to drill down into these specific details for any one province or even any one town, and actually where we can't really aim to do that. I'll put a question out there. Do we see any trends or methodologies within implementation research that you feel are really going to make a difference in the future of this particular field? Any one of our panels? Bianca, do you have any thoughts on that?
Thanks a lot, Dr. Roberts. It's really, we need to do something to improve the diabetes care. And I think what is needed, I think the initiative that you have taken now to show these gaps, it's really useful to know how to go further forward. I think one of the challenges with implementation research is this, that not one size fits all, but it shouldn't stop us from making some general recommendations that should be taken into account when you're starting new projects or going into to see how things work. And I think one thing that I perceive as often as missing is to see, like, we often have like a situational analysis of before we start a project and after, but in between, like, what happened? Why was it only 40% of people in this country that ended up receiving the treatment? So I think this is one thing that could really help to make better, I can say, granular steps of the pathway of receiving or providing some kind of intervention, being it preventive or pharmacological treatment of diabetes. I think that could be a thing to have some tools on how to better do that. That could really help, at least from my work. Right now, we are doing some country work where we have research implementation as a part of it to get the lessons learned. We're in 2 African countries now where we have specifically allocated funds and projects to make a report of the implementation research component of this work. But I think it's very, I feel a bit like it sometimes is overseen in country projects when you see so many people receive the treatment, but what was the reason for the gap in compared with the perfect target that everyone gets the benefit? Thanks a lot.
Thanks, Bianca. Sort of an open question for us all to sort of consider in the activities that we undertake. I see Catherine Lowe, great to see you here today. You've been a long-standing supporter of GACD. I see you're also raising the question. Did you want to verbalize the question, or are you just happy that it's in the chat there? Catherine, is still with us?
Could I say something?
Sure, absolutely.
Yeah. Hi, I suppose everyone has noted quite correctly the importance of context and the impossibility of knowing how something will happen in your particular region. But it troubles me greatly because we can't afford to do research on every intervention in every area. If we only get the high level messages, then they're very generic. I mean, they may still be useful. And I wonder if we may be thinking about research, say, for particular types of interventions. What are the generalizable messages from those interventions, or for particular types of settings, what are the generalizable messages from those sorts of settings? Because otherwise we end up with very broad lessons, which were beautifully articulated today, and they're useful, but they actually aren't sufficiently specific to allow us just to take the results of the research and do things in another setting without doing further research. So we can't always do research. We have to be able to use the evidence base we already have. Excuse me. So I guess I'm just articulating a long-held concern about how we can synthesize to best effect this wonderful program which you've put together. But many congratulations. It's really inspiring to hear about it all.
Thanks for that, Catherine. I agree, and I think it's interesting that in our report, one of the activities that was undertaken was to try to synthesize trends, commonalities in different ways. So by the implementation strategy, and actually one area is we tried to pull together strategies that had been used in different regions of the world to see if there were commonalities there. I think our report is really hopefully a springboard for further research. It's not the be all and end all. We know that actually even the impacts are not yet fully out there. I'm sure we've all know that age-old, well, it's not age-old, but that long-term held belief that, you know, it does take a long time to see the full impact of any element of research. But we hope that those impacts will grow. I do appreciate that, yes, there's that tension between the context specificity, the information required, and we do hope that there may be some generalizable elements that we can that will emerge in due course. I'm really sorry, but I see that time is running away with us. I need to take a few moments to say thank you so much to all of the introducers from the funding agencies, from all of the speakers and panelists who have contributed today. Thank you for taking time out of your very hectic lives. World Diabetes Day, I'm sure, is very busy for anyone interested in the topic area. Thank you to my team, and particularly thank you again to all those who contributed under the sort of lead authorship of Maisha, who prepared the report. Our diabetes report has now gone live on our website. The recordings of this session and the earlier session that we held today will also be available on our website, but probably not until next week. And there are materials available to accompany the report, such as various infographics, slides, etc., which anyone can feel free to use as long as you attribute the source of that material. I do hope that you have learned something today, that you have felt a little involved in the discussions, and thank you so much for joining us, and farewell.